I'm going to change focus a little bit from physician-assisted suicide to some beginning-of-life issues and hopefully end on a note of hope. First, the disclosures. I have nothing to disclose. I have no commercial support. Be nice to have some. So as I have no conflicts, there's no need to mitigate potential bias. We're going to talk about medical abortion. What is it? Or drug-induced abortion. And I'm going to split this into two parts. First, talking about what the regimens are, because there's more than one regimen, what their efficacy and their complications are, and then talk about the potential for reversal, including some information about malformation risk. So let's talk first about what are the regimens. There's misoprostol alone. Misoprostol is Cytotec, and you can use that alone to induce an abortion. You can use methotrexate in misoprostol, which is used to be the favored route in Canada. You can use tamoxifen in misoprostol, but there's really not much benefit to using tamoxifen. The most popular route is, of course, mifepristone in misoprostol, and up and coming in your time will be allopurinol acetate in misoprostol. So misoprostol, this is as of 2014. Misoprostol is approved in most areas of the world. There are a few areas where it's not registered as a drug, a legal drug, but in most areas it's very available and it's cheap. The overall completion rate is about 75% to 85% when used in the first 9 weeks of pregnancy. Now, we have an inherent bias in medicine. We look at the percents and we say, wow, that's pretty effective. What does a 75% efficacy mean? It means 1 out of 4 women will not have a complete abortion. That's important to understand when we talk about making medical abortion available in places where there's no access to hospitals. You have 1 out of 4 women now exposed to misoprostol, not aborting. Approximately 10% of women using misoprostol for early pregnancy termination will have an ongoing pregnancy. 1 out of 10. And in approximately 15 to 20% of cases, the abortion is incomplete. Now, what does that mean? It means in order for her to avoid sepsis, she's going to have to access a surgical abortion. So these are not numbers that come without meaning, and they come without meaning especially in resource-limited areas, the very place where misoprostol alone is being pushed. So this chart comes from the American College of Obstetrics and Gynecology, who have never met an abortion they didn't like. And this is their medical abortion practice bulletin. So I'm going to fill in the different regimens looking at the overall success rate, advantages and disadvantages, and gestational age at which it's used. But understand this is coming from a very pro-abortion standpoint. So misoprostol alone, the regimen is 800 micrograms vaginally or sublingual every 3 hours. You have a significantly higher incidence of adverse effects than other regimens, including nausea, vomiting. It is readily available and it's cheap, and you don't need any kind of a cold chain. The next regimen that has been used historically is methotrexate in misoprostol. You know, methotrexate interferes with DNA synthesis, and so any rapidly dividing cell is susceptible to being shut down in DNA synthesis by methotrexate. Methotrexate eventually kills the fetus, and misoprostol is used in those cases to then cause the uterus to contract and express the fetus and whatever's left. This was a very interesting article that was published just this year, looking at first trimester medical abortion practices in the US and Canada and comparing the two. At the time that they did their experiment, mifepristone was not approved in Canada. So they looked at 383 different clinics in the US and 78 Canadian clinics. And the 54% is, of all the clinics that they looked at, these are the ones who participated. Okay. So in the US, about 95% of the clinics offered first trimester medical abortion. In Canada, about 1 out of 4 offered medical abortion. 100% of the providers and physicians were Let me try that again. 100% of providers were physicians in Canada, which is good for you guys. Just under half were advanced practice clinicians in the US, which means that only half of the people dispensing medical abortion were actually physicians. All Canadian providers use misoprostol, and methotrexate, whereas mifepristone and misoprostol were the ones using, was predominantly being used in the US, and most had home administration. So what they found is you get about 95% of women with methotrexate who would expel completely up to 7 weeks, 49 days. Now, I know that you guys know this, but for the medical students who haven't been grilled in obstetrics and gynecology, gestational age dating is absolutely critical when you're talking about medical abortion, because the rate of complications increases dramatically as gestational age increases. The gestational age is from an idealized last menstrual period to whenever the end date is. So 49 days gestation is 7 weeks, but dated from the first day of the last menstrual period. So it'd be about 5 weeks from fertilization age. But when you get just a week later, you have only 82% complete expulsion, which means, again, about 1 out of 5 women have products of conception left behind. And for 20% of patients, the expulsion took up to 4 weeks, a whole month. So there are also some significant contraindications with methotrexate: coagulopathy, anemia, acute chronic renal or hepatic disease, acute inflammatory bowel disease, uncontrolled seizure disorders. All of these things should be screened for, but are they screened for actually in an abortion clinic? And an IUD must be removed prior to administration. So with all these contraindications and the fact that methotrexate directly targets the fetus, the rapidly dividing cells, the World Health Organization, who is now kind of the word to which all countries appeal for wanting justification for their abortion protocols. The World Health Organization actually recommended against the use of methotrexate because of the intrinsic toxicology. Although the actual risks are not actually known, limb defects and skull and facial deformities in pregnancies that continued after failed attempts to induce abortion with methotrexate have been reported. And it makes complete sense. Again, methotrexate targets DNA synthesis. So WHO said it's recommended that services wishing to introduce medical abortion methods use mifepristone and misoprostol. So yet ACOG, again, who's never met an abortion they don't like, lists methotrexate as a common medical abortion regimen and gives the overall success rate of 92 to 96%, which if you limit it just to 49 days is probably true. But again, if you get past that, even 3 days past it, you've got a much greater failure rate. Tamoxifen and misoprostol has been looked at. There's been randomized trials which demonstrated no benefit over methotrexate and misoprostol or misoprostol alone, so it's kind of been abandoned. But just put it in the back of your mind that that is possible. Mifepristone and misoprostol, this is what's used most around the world. This is where mifepristone has been approved around the world as of 2015. So most areas in Africa and South America have not approved mifepristone. And the areas of non-approval, the abortion pushers are using misoprostol alone. There were about 500,000 abortions reported to the Center for Disease Control in the U.S. In 2013, 22% were medical abortions, less than 8 weeks gestation. From 2004 to 2013, the use of medical abortion, which is mifepristone abortion, increased 110%, from 1 out of 10 to about 1 out of 5 abortions. Okay. So again, this is the WHO guidance on safe abortion. Less than 9 weeks, this is the regimen: 200 milligrams of mifepristone, 800 micrograms of misoprostol per vaginal, buccal, sublingual, or 400 PO. 9 to 12 weeks, 200 milligrams of mifepristone, followed by 800 micrograms of misoprostol per vagina, Q3 hours up to 4 doses. 12 to 24 weeks, 200 milligrams of mifepristone, followed by 800 micrograms of misoprostol per vaginal, or 400 micrograms PO, followed by repeat doses. I want you to notice something. This is safe abortion, according to the World Health Organization. By the way, this second edition was actually written by a notorious abortionist who was actually drummed out of his country for doing illegal abortions and then came back and got a job at WHO. This is from a study from Finland. The advantage in Finland is the state owns the medical record. So this was a whole large study looking at immediate complications after first and second trimester abortion. Now, this title is one of 3 sets of papers that came out of this database. So I've looked at the original database, and this is one of the papers, but this graph is particularly important. Can you see my little arrow? No, you can't. Okay. Well, you'll just have to look on the y-axis is the percent of patients needing surgical evacuation after the procedure. And on the x-axis is gestational age in weeks, okay? So you can see at, say for instance, 10 weeks, you got 1 out of 10 women who need a surgical evacuation. When you get up to 13, 14, 15, 16 weeks, you've got up to 45 to 50% of women needing a surgical evacuation after medical abortion. And I want this graph to sink into you when you hear the argument that medical abortion is needed in resource-poor areas where women can't access health services. You know what? These women die. They die. A 14-week fetus left inside or placental tissue left inside in a woman who can't access a surgical completion, she's going to hemorrhage to death. This is safe abortion according to the WHO. And they're recommending over 24 weeks, you use mifepristone and misoprostol. Remember, over 24 weeks is survival. Okay, this is fetuses that can live as preemies outside the womb. Now, I want you to, sometimes you got to laugh because you cry. The lack of clinical studies precludes specific dosing recommendations, but hey, use it anyway, despite the lack of clinical evidence. This is a legal document that's used legally to justify medical abortion under any circumstances, because the practitioner can always say, well, WHO recommended it, and I'm just practicing according to WHO guidelines. So again, even though we would wish that the WHO would stick to medicine instead of ideology, these actually are legal documents for legal protection of the abortionist. As of March 2016, mifepristone, which is the 2 regimens at the top, the original FDA regimen and then the regimen below it. As of March 16, the regimen below, which is the oral 200 milligrams of mifepristone followed by 800 micrograms vaginally, buccally, or sublingually, was approved up to 70 days, despite the fact that they only had a few people in the studies that were used up to 70 days. It was a complete give-in to the abortion industry. So this is the study, this is part of the database that I talked about in Finland. And the reason I wanted to bring up this particular one of the 3 papers is that this is 42,000 women who underwent a surgical abortion whose medical record is known. I mean, they have the records there. Half of them had surgical, half of them had medical. They were matched in other ways. Followed up for 42 days, so it's a short follow-up. But what they found was the overall incidence of adverse events in medical abortion was 4-fold higher than in surgical abortion. 20%, 1 out of 5 patients, had a complication versus 1 out of 20 patients who had a surgical abortion. And this was very statistically significant. The risk of hemorrhage, about 15% for medical abortion, about 2% for surgical abortion. Risk of incomplete abortion, about 1 out of 20, 7%. Surgical abortion, 1.6%. And the risk of emergency surgery was about 1 out of 20, 5.9%, versus about 2% for surgical abortion. So the emergency surgery was done for reasons of mostly hemorrhage. So this isn't just a surgical follow-up because of an ongoing pregnancy. This is actual need for emergency surgery. All right, why do I have misoprostol in here, Ella? Because this is the wave of the future, and you should know about it. There are other names that Ella goes by, CDB 2914, VA 2914. If you want to look up the actual pharmacology data, this is what it's listed under, the AKAs here. This was a very interesting article by Mitchell Krynen. I don't know if you know Krynen, but he's a prominent abortionist. And he was waxing eloquent about Ella and its potential uses in the U.S. And I bring this is just my own pet peeve. The development of RU486 and Ella in the United States was supported by federal funds from the National Institute of Child Health and Human Development, NIH. That's our tax dollars at work there. Sorry about that. This is what Mitchell Krynen said. Progesterone receptor modulators offer another option for emergency contraception that maintains effectiveness. Potential for widespread availability of mifepristone as an emergency contraceptive is often limited for social or political reasons. However, Ella is a second-generation progesterone receptor modulator that has a lower anti-glucocorticoid activity than mifepristone, which is the first-generation progesterone receptor modulator. So what you have to understand about Ella and mifepristone is that both of them are the same class of drug. And Ella actually is equipotent with mifepristone. The big push to make it an emergency contraceptive is to make it available eventually over the counter, because that will solve the problem of access for abortion. So this was this was a statement made by one of the Reproductive Health Advisory Committee members. I was at that meeting when the advisory committee met to decide whether or not to approve Ella as a emergency contraceptive. And Dr. Emerson said, the big elephant in the room always when we have these discussions around here is whether or not this medication is inducing some type of termination, acting as an abortifacient after fertilization has occurred. Yes, Dr. Emerson, you're right. This is an article that I helped to co-author called Defining Reality. And in it, a pharmacist and I went through what would be the animal studies looking at the abortifacient effect of misoprostol, and how do you bring that out to the human dose? So I wish I had a little, okay, so on the left side of the little box where it says rat, rat, monkey, monkey, that tells you the species that it was done, and they looked at the two different endpoints of no abortions versus 100% abortions for the rat. And the approximate equivalent human dose is 11 to 33 milligrams. So Ella is 30 milligrams. Okay. In the monkey, it's not quite the same. It's not quite as effective. So the monkey, for 0 abortions, it's around 12 milligrams in the human. But if you get up to 120 milligrams, you got 40% abortions. And again, it depends a little bit on gestational age. But this is a selective progesterone receptor modulator. This causes abortions. Further experience with abortion in humans is supplied by the 2 phase 3 trials which were submitted to the FDA for approval. That's what the Reproductive Health Advisory Committee was reviewing. 2 of these trials provided information on pregnancies conceived after misoprostol administration. In the first 5 out of the 6 pregnancies with a known outcome, 5 out of 6 ended in miscarriage for those who didn't choose to abort. And in the second study, 4 of the 6 women who had a known outcome of a pregnancy conceived during the trial miscarried, and the remaining 2 were lost to follow-up. So that is what prompted Dr. Emerson's question, he said, you, the manufacturer, have a problem. You have a way too high miscarriage rate. What do you say about that? And they said, Ella works by preventing ovulation. Oh my goodness. It was, no matter what question was asked, the answer was, Ella works by preventing ovulation. So now we have a triumph as of January 2017. Ella is over the counter in Australia. And this is the ultimate goal, is to make Ella over the counter worldwide, because that puts a powerful abortifacient drug, equipotent with RU486, in the hands of every woman. Cytotec is very easily available, so it's an easy jump. What else is happening is that there are currently 86 different websites where a woman can go online and order mifepristone abortion kit from China and India. And the wonderful thing about these websites is if you order from them, there are no complications. It is 100% effective. You can do this in the privacy of your own home. You ought to do this. Go on and Google it. Look at the promises. And who regulates this? It's international commerce. Who can regulate this? So there was a review of these online sites. Somebody went on from the pro-choice side and ordered, and they got 42 different kits back, and they extolled the wonders of how this is going to increase access for women. No physician or healthcare provider was involved in this transaction. There was no confirmation of gestational age, no even confirmation that the woman's pregnant. All she has to do is order online. How does she know she's even pregnant with more than a chemical pregnancy? No concern about the exponentially increasing rate of hemorrhage and complications after 7 weeks. No concern about the lack of access to emergency room services. No concern about the fact that these online pill packages came without any package inserts or instructions. They said in the article, well, women are well capable of going online and finding out how to use them. No concern about the fact that the 20 tablets labeled 200 micrograms misoprostol contained 34 micrograms misoprostol up to 201 micrograms of the active ingredient. No concern about the easy access for pimps or abusers who can get a discount for packages of 10 or more. Why should a drug pusher care about the women who are hurt? So stopping the supply of mifeprex and Ella to the general public has been unsuccessful due to a lack of political will. Currently, there's de facto over-the-counter availability for both mifeprex and Ella with little ability to regulate. But for those women who regret starting their abortion, there is hope. So we're going to talk now about the more hopeful part, the potential for reversal. And I'll start first with methotrexate. It is theoretically possible to reverse methotrexate with a leucovorin rescue. The concern has been that because of the way methotrexate works, it directly targets fetal tissue. There's a concern for fetal malformations. And I know of no current protocols using leucovorin rescue, although of course it is theoretically possible. But there are protocols for reversing mifepristone. And in order to talk about those, I want to talk about the function of progesterone in pregnancy, the evidence for reversal of progesterone receptor blockade, and the current case series of reversals that have actually happened. So we're going to do a little chicken wire drawing. This is progesterone. At the top of progesterone is a little entity that gets substituted, and at this part of progesterone is a little entity that makes you a progesterone receptor modulator. So we'll look at mifepristone on the left and elapristol on the right. You can see that what's different between progesterone and mifepristone and Ella is the moiety that's up on the pentagonal chain. And also this particular moiety which makes you a selective progesterone receptor modulator. So they're very similar drugs. So what they do is they fit into the progesterone receptor and they block it. But it's a reversible blockade. Well, what does this mean? As a good Lutheran, you always have to ask, what does this mean? So this is the non-pregnant cycle, and I'm going to take you through it just kind of real briefly. I don't want you to look at the details, but just kind of look at the overall picture. You can see at the top, that's gonadotropins, LH, FSH. You can see the second line, which is steroid hormones. The top one's estrogen, the bottom one's progesterone. You can see the ovarian cycle in the middle where it goes from white to gray. That's follicular rupture with egg release. And at the bottom is the endometrial cycle where you have the growth in endometrium under the influence of progesterone and then the twisting of the arteries under the influence of progesterone. And that's what it looks like when you're not pregnant. You notice that the progesterone falls after the mid-luteal phase, and then with that fall in progesterone comes a degradation of the endometrial lining. If you're pregnant, however, things look a little different, and progesterone doesn't fall. Mid-cycle, at the time of implantation, the embryo elaborates HCG, which maintains the corpus luteum, which we learned about yesterday, and you get implantation. So just keep this in mind, because we'll come back to it. If you really want to know about selective progesterone receptor modulators, you have to look at this document by the guy who actually developed them, Bellieu. And this was written back in '86. And all of this research was done in '86. This is like a probably 300-page document compiling everything known about progesterone receptor modulators. So what he diagrams is that RU486 as the prototype progesterone receptor modulator affects not only the endometrium but also the ovary. So when you go back to this cycle, RU486 works here at the level of the gonadotropin surge, and it will blunt LH. Okay? Blunting LH is important because the area under the curve of the LH surge is directly proportional to the amount of progesterone produced in the luteal phase. Why is that? Because LH is what takes those nice little granulosa cells and turns them into luteal cells. It reprograms. So if you blunt the LH surge, one of three things happen. Either there isn't much of a blunt, the egg's released and there's a happy amount of progesterone produced second half of the cycle. Or it's really blunted and there's no egg release, which is why the manufacturers of Ella could say the answer to every question is Ella works by preventing egg release. Yes, well, taken 3 days out of the cycle, it does. Or there's another thing that can happen, and that is that egg release can be prevented, the LH surge can be blunted, but not enough to prevent egg release, but enough to prevent sufficient progesterone production in the second half of the cycle. It's an induced luteal phase defect. So that's one way that Ella and mifepristone both work, is at the level of LH. They also work at the level of progesterone production via the blunting of the LH surge. But it's more than just blunting the LH surge. If they don't prevent ovulation, they cause a degradation of the corpus luteum. So at times where the egg's been released and then Ella or RU486 is taken later, there's a direct effect on the corpus luteum to cause degradation of progesterone-producing cells. They also work directly to block the effects of progesterone on the endometrium, and they work to prevent the maternal response to progesterone so that there's a degradation in the ability of the mother's spiral arteries to form a decidual reaction. So they work. Ella works in all those ways, as does RU486. The action on the already implanted embryo is how RU486 causes an abortion. That's the molecular mechanism. So something that you have to understand is that hormone receptors, if you've had your biochemistry, you know that a receptor interacts with drug. And in the case of progesterone, when the progesterone and the progesterone receptor bind, then there's a change in DNA transcription that produces the progesterone reactions that makes the cell act like it's been exposed to progesterone. But when an anti-hormone binds to the receptor, there's a transformation, but the complex isn't as active, or it has no effect in inducing the progesterone transcription effects. So there's no biological response, and that's how it works. The issue is these are competitive binding. So if you remember from your biochemistry, competitive binding means that if you got lots of progesterone, you can kick the RU486 off of the progesterone receptor. Is this really true? Well, there was a very interesting study done in rats, which actually showed that after you give pregnant rats RU486, if you give them progesterone, the effect of RU486 on the corpus luteum is minimized. So after 4 days, 66.7% of rats given mifepristone alone aborted, but 100% of rats given progesterone in addition to mifepristone failed to abort. Yamibi is the one who did this study. He did actually 3 papers on it. Yamibi demonstrated that mifepristone blockage of progesterone receptors was reversible, and that progesterone rescue could block the abortifacient effect of mifepristone if given very soon after the mifepristone dosing. Survival rates using total doses of So this study that I have up here is actually in the Issues in Law and Medicine journal that's over there, free for you to take. And what it did is, this is a systematic review of the literature, the world's literature, looking at what is the actual baseline embryo survival for fetuses who are exposed to mifepristone alone, but not to misoprostol. So survival rates using doses of 200 to 300 milligrams ranged from 10 to 23%. Regimens with doses greater than 400 milligrams had lesser survival rates. So again, part of the difficulty in analyzing this is there's doses of mifepristone all over the board, but Dr. Davenport compiled the information for what's currently used in our country, in the US, which is 200 milligrams or 400 milligrams of mifepristone. Embryo survival studies included gestations up to 75 days, which when you take it out further, there are embryos that survive at 5 days. There are embryos that, there's less embryo survival the earlier in gestation. The further in gestation, there's greater embryo survival, but again, it depends on what the dose was, and it also depends on how long you follow. So for instance, with the Ella studies, where women were pregnant and then they miscarried, the miscarriages didn't happen immediately. They happened after a period of time. And so depending on how far out these studies looked will affect what you have as a survival rate. But this paper is important because it gives the actual survival rate instead of what's claimed by Dr. Grimes, famous abortionist who authors the ACOG abortion practice bulletins. He quotes a 50 to 60% survival rate. Where does he get that? Thin air. So knowing that there's a low survival rate with mifepristone alone, knowing that mifepristone is a reversible blocker of progesterone, it's just common sense and practical toxicology to say if you got a poison, you give an antidote. And so Dr. Delgado, Dr. Davenport, and Dr. Matthew Harrison, no relation to me, published a case series where they actually did look at pregnancies, and they did give mifepristone, and they had about 6 survivors. Did give progesterone? Not mifepristone. These are women who were exposed to mifepristone alone. They gave progesterone, and they had 6 survivors, the first case series. The other information that can help you is a look at survival that was published in 2013 in BJOG, British Journal of OB-GYN, which looked at 105 pregnancies exposed to mifepristone alone, and what was the live birth and miscarriage rate afterward. So these are pregnancies that survived the initial mifepristone misoprostol dosage and went on, because there are a few survivors. And what this paper tells us is that there were really pretty minimal malformations, which is the big fear in this reversal. How many of these babies are going to be malformed because of being exposed to mifepristone and misoprostol? The overall rate of major malformations was 4.2%. The current general population rate is 2 to 3%. So in this journal, in this publication in BJOG, the conclusions were that the rate of major malformations after first trimester exposure to mifepristone is only slightly higher than the expected 2 to 5%. I think it's more like 2 to 3% rate in the general population. Okay, so the increased risk of congenital anomalies were related to misoprostol are an issue because there is some literature looking at misoprostol, the second drug, Cytotec, which shows an increase in any congenital defect, about a threefold increase, specifically an increase in Mobius sequence, which is a specific pattern of limb restriction, and terminal transverse limb defects. So there was a 25-fold increase in Mobius sequence and a 11-fold increase in transverse limb defects after exposure to misoprostol. So misoprostol seems to be the teratogenic agent. The mechanism for that is that misoprostol induces contractions, spasmodic contractions, which interferes with the blood supply to the developing fetus. And so that's why you get these focal blood supply type things. It looks like there's little strokes in the placenta. And that's how misoprostol induces these defects. In conclusion, prenatal exposure to misoprostol is associated with an increased risk of Mobius sequence and terminal transverse limb defects. We know that. Which also makes it particularly heinous that people who argue that abortion is needed in resource-poor areas, so that medical abortion is needed, so we're going to give them misoprostol alone. Again, knowing that there's a high rate of malformations, knowing that there's a high rate of failures, it's just heinous. All right, so this is just basically saying the same thing. Okay, now what about progesterone? Because we're not only talking about exposure to mifepristone, but we're also talking about exposure to progesterone. This is natural progesterone. Natural progesterone has actually been used in the infertility industry for about 40 years in the United States. It has a very, very, very long safety record, including use for luteal phase defect. But also in IVF, most women are supported with progesterone during their luteal phase after transfer. So there's a long history of safety with IVF. Now, in the progestin literature, which is the artificial progesterones that are not exactly progesterone, they're analogous. There is a question of whether there's an increase in hypospadias in fetuses that are exposed to progestins, but not progesterone. So in 1999, the FDA review concluded that there's no risk of birth defects, including hypospadias in women taking progesterone or 17-hydroxyprogesterone, which are both natural progesterones. So this is the American Society of Reproductive Medicine. Again, a long history of using progesterone, and this is a cover yourself statement by the ASRM. But while they say, while there are no long-term adverse consequences of progesterone, the safety of this or any drug cannot be guaranteed, so the FDA requires inclusion of a package insert regarding synthetic progestins with each progesterone prescription. These drugs have progestational effects, but also have other effects which progesterone does not have, including male hormone effects. So synthetic progestins may not be safe in pregnancy, but progesterone is safe in pregnancy. So what we see when we look at the concern for malformations, if we try to reverse, is there's really no good data that suggests that there's an increase in birth defects with mifepristone exposure alone. There is data with misoprostol alone that there's limb reductions and facial paralysis. And when you see both, you see limb reductions and facial paralysis, which is probably due to the misoprostol exposure. So, where are we at? Well, if you go to abortionpillreversal.com, you will find a hotline. This is Ashley and Kaylee, the first RU486 reversals. And there have been over 300 births now after reversal. There's about 150 women currently pregnant after the reversal. With the best protocols, that is high-dose oral and IM progesterone, the reversal rates are 60 to 70%. It's not perfect. It's not 100% reversal. It depends a lot on how long the woman goes from taking the misoprostol to taking the progesterone. The longer interval, the less chance of success. But in this case series, which is about to be published, it's not yet published, there were no increased birth defects or prematurity risks. And this is the hotline, which actually, fortunately, all of you guys on your table should have these little cards. You should see them. Please take them with you. Our goal, every time we speak about this, is to saturate your local area with these cards. Take them to Starbucks and put them in the women's restroom. Take them to the campus bathrooms and put them in the women's restrooms. Because a woman only has really max 72 hours. It'd be best if she got progesterone reversal within 24 hours. And in order for her to do that, she needs to know it exists. And in order for her to know it exists, she has to know about it before she gets pregnant. So we have a huge public information campaign that has to happen. And I would encourage you to take those and copy them, distribute them, because we need to let people know that there is hope. There's hope. If you change your mind and you regret what you did, there is hope for reversal.